Well, good afternoon or morning, everybody, depending where you are. We're going to talk about thumb carpal metacarpal joint or CMC joint arthroplasty using the SpeedSpiral biologic implant. So I'm sure most of you know about this implant already, even though it's just been released. It's basically a denatured, there's no antigenic material left in from human collagen, and it's rolled up kind of like a fire hose. So it's a very tight spiral roll. And the idea is that while arthroplasties work very well on the whole, soft tissue wise for pain relief, they aren't really great in pinch strength. And most of the previous implants that have been designed here have relied on metal and plastic or some other non-biologic material and have generally failed over time. So trying to accomplish maintaining the height of the thumb, avoiding the collapse, allowing a stable fulcrum for pinching, yet having something that is accepted by the body and once incorporated essentially should last the patient's lifetime would be a potentially good option for people down the road. Oops. Okay, so thumb arthritis, so how do I go forward? Okay. Thumb arthritis is really incredibly common, and this is the most common operation done for arthritis in the hand. It's also the third most common operation for arthritis in orthopedics, and that includes, so it's hips and knees, and then the thumb CMC joint. There are about 100,000 cases done a year in the United States, and probably about 200,000 or 300,000 done throughout the rest of the world. And that number has been increasing as the demographics of the population get older. So the baby boomers are getting older, and we're starting to see this far more frequently. In my practice, I'll do between, some weeks I'll do one a week, and some weeks I'll do 5 or 6 a week. So it kind of comes in waves occasionally, and there are certain periods of the year that are a little slower than others, and then there are periods of the year that are much more common, and that's, common in surgery in general. But I'd say it averages about 2 to 3 a week, so it's pretty common for a hand surgeon. You have to remember that all the techniques, the soft tissue techniques that are done today, work pretty well, but the morbidity varies by each procedure, and the time to perform the surgery, how long it takes to actually accomplish the surgery, varies greatly as well. The LRTI, which is the most common, probably still the most common procedure done in the United States, maybe a little less so in Europe, is a ligament reconstruction tendon imposition. So you take out the trapezium, which is common to most of the surgeries performed. That's where the arthritis is. The trapezium bone gets removed, and that's on the bottom of the thumb. And in the LRTI, you use a flexor carpi radialis tendon and make a weave, drill a hole through the thumb bone, and then pin the thumb joint. These generally require a cast because there is a pin in place. Requires a tendon harvest and takes about 45 to 60 minutes to perform, but really doesn't cost a lot. It costs a K-wire and it costs a drill bit, so maybe 100, 150 bucks to do the case. Suspension plasty, which I've done in my practice for about 10 to 12 years now, can use a variety of techniques. One of the most common popular ones today is a tightrope from Arthrex, which is a suture plus a button technique. It's a fairly expensive little device, about 1,600 bucks. You can also do it with a new technique using a weave fashion. It's not actually new, it's been about 10 years, but we just published it in the Journal of Hand Surgery a couple of months ago, and that just requires a number 2 orthocord or fiber wire suture, so it's about $50. So that can be done with just a splint only and takes about 25 minutes. You can also just take out the trapezium itself and do nothing else. This was done in Britain a lot and in Europe for a while. It's very cheap, it's easy, and a lot of patients do pretty well with this, although there is a fairly significant risk of collapse because there's nothing there holding the thumb up, and so it does collapse, and there are a lot of patients with secondary problems. So that's not a particularly elegant or robust or popular procedure these days. In Europe, they use a lot of metal and plastic, like little mini total hips, for doing this procedure. Some surgeons are very good at putting those in, but the overall history of those long-term has not been good. as has been the case in the United States with metal and plastic implants. You might also remember there was a device called the Artelon, which took the hand surgery world by storm. It was basically a I think it was polylactic acid weave that people put into the joint, and it worked great for about 2 years. And then, as with all these polylactic and polyglycolic acids, they started making mast cell degeneration, kind of silicone synovitis reaction, and they had massive erosion of the bone because it was not a substance that could be eaten by the body, and the mast cells could not phagocytose it. They couldn't eat it. So there was a degranulation reaction, and that ruined the bone. So it wasn't a biologically appropriate solution. And so a lot of those got taken out, and that was taken off the market. It was basically a disaster. The idea of the SpeedSpiral came about 30 years ago when I was a hand fellow. I trained with a guy named Jim Strickland, who was president of both the American Society for Surgery of the Hand and the American Academy of Orthopedic Surgeons, very famous guy. And he got the idea of just taking a vascular Gore-Tex graft that's used for bypass surgery, flattening it out, so it's a round tube, it looks like basically a long tube, flattening it out, and then rolling it up like a fire hose, and getting it just to the right size where so it fits about what the trapezium looked like, and then putting it in the hole there to suspend the thumb to improve pinch strength. And those patients also did extremely well for 2 or 3 years, but they had the same problem that the Artelon patients had. The Gore-Tex material started to degrade, pieces would start coming off, and the body could not handle the pieces, and there was significant reaction to that. When I got here in practice, I did notice that the patients did incredibly well functionally with those devices, and so I was thinking about what could we do to replicate that, but that wouldn't be adversely reacted by the body. And I tried, I basically got denatured bovine collagen that was used and approved for rotator cuff repairs, and I cut it into a long strip and I rolled it up like a fire hose on the wall, put a suture through it, and then I put those in thumbs. And those patients did very well. I did the first ones about 20 years ago. I've never had to take one out, and they had excellent results. But it was not it was an off-label use. There was a company that was interested in doing it, but they were essentially told they have to do a PMA because it was a different location for bovine collagen. To make a long story short, they said, we don't want to spend that kind of money, and it was dropped. But the patients did really well. So now you get to these days, and Arthrosurface has different materials. Human collagen is appropriately approved by the FDA for use in this location. And it's essentially the same thing. It's a rolled human collagen, completely biologic, doesn't have a reaction in the body, and gets incorporated into the body, yet maintains its stability. So why SpeedSpiral? Well, basically, if you look on the left-hand picture, you can see how the thumb bone on the left, where the left arrow is essentially sitting on top of the scaphoid bone where the right arrow is. And this is after an LRTI, which shows this can even happen after the reconstruction procedures. So the normal space where the trapezium was when it was taken out was not maintained, and the thumb collapsed into that pocket. And that makes the thumb shorter, but the tendons are the same length, so people lose strength. If you look on the right, which is a patient I recently did with a SpeedSpiral implant, you can't see the implant. All you see is the hollow space between the base of the thumb, the left-hand arrow on the right picture, and the right-hand arrow is at the distal scaphoid, and you see this white space between the two bones, and that's being held up in space by the SpeedSpiral implant. So here the thumb doesn't collapse, and therefore the pinch strength is very good. Obviously, we don't have a lot of follow-up on, we've just been starting to put these in, but I saw this patient back at 1 month. He felt great and had excellent pinch strength going forward, but is still in therapy. So the idea of this is to solve the problem of collapse, to provide the same amount of pain relief as all the other techniques that are out there, but get a better print strength for the patient, both short-term and long-term, in a solution that's biologic, that doesn't get the body doesn't react adversely to, and should basically last forever. So here's basically what it looks like when you take out the trapezium bone in the thumb. You take this rolled implant, and it comes in 3 different sizes, and you place it in that space, and you want to anchor it in place. There's a spacer trowel and a delivery tool, which is used to drill the little holes for the suture. I didn't really use either of these. I just kind of looked at it. I did try the spacer trowel just for kicks, but you can pretty much guess the size from looking at the hole. The surgeon should be able to guess it. You can also change the size by unrolling it a little bit. So I had one case where I used it not in the thumb in another location, and I needed it smaller. So I just started unrolling it until it was the right size, and then I cut it off. And the rest of the rolled up implant maintained its shape, put it in the location I needed it. And so it's a bit customizable. So if you're not sure if you want a 13 or a 15 millimeter one, you should always pick the larger one, because it can be unrolled and you can cut the material with a knife, rather than a 13, because if it's a 14, you can't make a 13 a 14, but you can make a 15 a 14. So always err on the side of a larger implant, and then just unroll it if you need to. This is pretty hard. When you take this out of the packing, feels like a rock. So it's not a squishy thing. It's got lots of substance to it. It's very highly compressed. And my impression is I soaked one of them for about 30 minutes, and basically the top 0.1 millimeter got a little soft, but the rest of it was still hard. So I think what happens to this, although we don't know, but I think happens is that it will very slowly soften over time, but that probably 80 to 90% of the structural strength of the implant will stay no matter how long it's in the body. So here's a patient I did the other day. There's a small incision, about 3.5 centimeters made over the base of the thumb joint. The incision is a little bit of an S-shaped curve, because you do want to keep the abductor pollicis longus tendon, which is that white tendon you can see kind of at the top right of the incision. You want to keep that intact on the thumb metacarpal. And then there's the muscle, the thenar musculature, which is on the left upper side of the incision. You want to take that off the bone. If you looked at the right-hand picture, you can see the carpometacarpal joint, that black hole, and then the trapezium bone that we're going to take out is right behind it. That's where the gold arrow is. I have a little custom-made corkscrew that I screw into the trapezium bone, which allows me to maneuver it around and hold it. And then I use a retractor made for the foot originally, called the Maglamry retractor. I use a number 11, and you can use this to dissect around the trapezium, using the corkscrew as a joystick, essentially, and you can take that entire trapezium out in one piece using the retractor tool. So now the trapezium's gone, so now we've got to put in our suture that's going to hold the SpeedSpiral in place. So if you look in the depths of the wound, you can see that tendon that's running nearly vertical. That's the flexor carpi radialis tendon. And what we want to do is put one suture through that tendon, and maybe a little bit of the capsule that's right next to it. And then I put a second suture in place right next to it again immediately, and I'm going to lock it. So I'm going to take the suture and put it through the loop and make a locking stitch. So it's at the very distal part of the FCR tendon. We're pulling on the thumb, so we're trying to distract the thumb as much as possible while doing this, putting the suture in. And you get kind of a locked suture in place. And then I just took the trowel there, stuck a number 15 in there, and just moved around the thumb to see if that was about the right size, and it felt like that. Then you can take the little drill device, or you can do it freehand, either way. So the left is drilling it through the drill device. The right is just holding it freehand. And you could drill a K-wire that has a metal loop. This comes in the set at the end of it. So when you drill the K-wire through and you take off the drill, there'll be a little metal loop. You just put the suture through that loop and you pull the K-wire through. As you can see, one hole is that's already happened in one hole. And you end up with this. You end up with a suture that's affixed deep in the wound, locked in place, as far distal as possible, 2 sutures coming out of it, going through the SpeedSpiral implant, and then you slide the implant right down with your finger as hard as you can. I was actually pushing on this implant with a retractor, pushing down on it while my hand surgery fellow was tying the knot. So you want to kind of push it in there as much as you can, and then have someone else tie the knot nice and tight, probably 6, 7, 8 knots, so it's really strong. And then you just close up the thenar musculature and the abductor pollicis longus to the capsule, so you close around on top of the implant itself. Then you want to just move the thumb around, take a feel, make sure it feels pretty good. The implant's not moving around. And that's essentially the procedure. This one that I did on Wednesday took 21 minutes. There was excellent immediate stability. We put a little plaster splint on. We don't really put it around the thumb. We just put it around the base of the thumb where the muscle is. And that stays on for 8 days. And then the patient gets a removable splint at therapy. They do start some gentle motion exercises for the first month. And then after the first month, they go into a small thumb splint that's used between exercises, but then they can really start to work on strength and exercises. And at 8 weeks, 2 months post-op, they don't wear a splint at all anymore. And, I think that, our experience is very early on this, but the first few patients seem to have done very well. And we're going to do a case cohort study here where we're going to do the suture suspension on half the patients and the SpeedSpiral on the other half of the patients to compare the outcomes between the 2 groups going forward. Some surgeons asked about, a lot of implants materials have been tried in the past and they haven't worked. And I think that's really true, except that no real implants have been tried that are biologically appropriate. So the Artelon device was a bad material. Polylactic and polyglycolic acid have long been known to have joint reactions. Silicone really hasn't worked very well because of particulate debris. The metal and plastic ones also are particulate debris. There was a trial of a graft jacket, which is essentially a kind of bovine and human denatured collagen, where they just basically take the shoulder stuff, similar to what I did, roll it up. They didn't roll it up in like a fire hose thing. They just kind of made a folded blanket out of it and put it in the thumb. And those patients actually did pretty well as well. But it doesn't really fit the joint space itself, and it didn't have a rounded contour so that the thumb joint could roll over the implant itself. So I think this is a good solution, and I don't think there's really been anything out there that answers the question in the same way. There's a question about, do you foresee not being able to see it on x-ray as an issue? What you don't see sometimes is good in surgery, because when you see it and it goes out of place, it's a bad thing for the surgeon. It gives them a lot of angst. And essentially, if this implant stays in place, you'll know it because the thumb will be at its normal height. So I actually don't see any reason to want to see the implant, because if it weren't in the right spot, I think that the thumb would collapse and you would know it very quickly. So you'd see that the bone collapses. So I think it's an indirect way of seeing it, that the implant's doing its job. There's another question here. Yeah, so about the failure modes of previous implants. Most of the failure modes on the total joint type implants have been that the implants loosen. They are either cemented into place or a press fit. And they really have not had a good track record, no matter who's put them in over time. And that's why they're very unpopular in the United States. There are a couple new implants, one that I was involved with too, that tried to replace the implant, that were made out of metal and some metal and plastic components that didn't have a ball and socket design. And patients, they felt the patients did pretty well, but they all complained of a low level of ache because the metal was so hard against the bone, against the thumb joint, that I think they had this kind of constant ache. And I had to go back in on several of those and take the implant out just because the ache was bothering them too much. So I became very unhappy with those devices just because they didn't solve the pain problem entirely. Does he think it matters which way the graft is laid when implanted? That's a great question. I don't think it matters. I prefer the way I showed you, where the rounded part is against the thumb bone, but I have put it in the other way, 90 degrees, where the rolled up part is against the thumb bone. I think that's a flat spot, and I think you want the thumb to roll around the end of the implant. So I think that's less ideal. But do I think it's all going to fall apart or anything? No. But I think the way the implant is shown in the illustration in the technique brochure or sales brochure, I think that's probably the better of the way, because you're compressing the layers of the rolled implant against each other, which just makes more sense biologically. And the other question, is it important to suture this implant in? Yes. The one problem you can have from you put a device in a hole, the big problem is if it doesn't stay in the hole. So you can kind of say, well, if I push it in there and I try to close the soft tissues on top of it, that'll probably keep it in place. And it might do that. But think about it. Once you try to start closing the soft tissues around the implant, you're not pushing the implant in its place anymore. And it could already start to push out a little bit while you're closing up, and you won't see it because you're closing the tissues. So I think it's really critical to put the suture in nice and solid in the bottom, yank on it, make sure it's really rock solid, and then really put it through the implant, push the implant down there as hard as you can, and then tie it as tight as you can. I think that gives you pants over vest stability. And then, you can go and close the capsule and the muscle above it, which will give you even more support. But I would not recommend not fixing it. I think it should be fixed with a suture. Hand surgeons are creatures of habit, just like orthopedic surgeons. They're going to like what they do. There are lots of guys who do LRTIs, even though it takes them an hour to do it. They've done it that way all their life. They're not going to change. And they know the data is better for things like suture suspension. The morbidity is less. And this device, you're not really competing against it. What you're trying to do is add something to the procedure that isn't currently there. And the thing that's missing from every soft tissue LRTI, suture suspension, is power pinch strength. Really, where patients can actually grab something and really pinch hard. And that's generally never gets back to normal. And the idea of this device is to allow a stable structure in there that supports the thumb, so that when you pinch against something hard, it doesn't just collapse, and it gives some resistance so the patient has power to be able to push against that. And so I think for younger patients, this is really important, because they're going to be much more active than a 90-year-old. Maybe in a 90-year-old who's sitting around not doing much, it doesn't really make a difference what you do. You might be able to do a trapeziectomy and get away with it. The other thing is time saved. I do think, for me, doing something that takes 20 minutes versus doing something that takes 45 minutes or an hour, that's important. I think patients don't like a cast. They don't like a pin put in their hand. They feel that in the cast. It rubs the end of the pin, rubs against the cast. And they don't want a tendon graft taken out if they don't have to. So I think this provides the strength, the plus part of the strength improvement, and it saves time. And if I can do 2 of these in an hour versus 1 in an hour, that's to me, that's certainly worth it. That's something, a little bit of this is time will tell, because when we start having studies that show that the pinch strength of this device is much better than the pinch strength of an arthroplasty, soft tissue arthroplasty, you can bet then patients are going to want this device. And that data is going to be out there in a year. There's going to be a study published that has 2 different groups, and you're going to see that data, and then patients are going to say, I want the one that makes me strong, not the one that makes me weak. The question from Ryan: is this a good revision option for a failed LRTI? Yes, 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 yes. Because whenever you have a failed soft tissue reconstruction, the thumb is short. It doesn't want to go back to where it was. It wants to stay short. It got used to being collapsed. All the tissues have tightened up around it. It all looks like a big mush ball in there when you go back in after a failed LRTI. So in this case, this is the ideal setting for this. And I was talking to another surgeon at Stanford the other day who said, God, I got this revision. This is exactly what I need for the revision, because you can basically carve out all the mush junk that's in there, make your hole, pull the heck out of the thumb, but now you have something structurally strong to put in that place, instead of trying another LRTI, which is just a tendon, which is kind of elastile a bit. It's a little bit like a rubber band. It's just going to collapse again. So I think revision surgeries, this is super ideal. What size suture do you use to lock it in? I prefer a number 2 ortho cord or fiber wire. Those are braided, incredibly strong. They do not get resorbed by the body, so they're there kind of forever. I have seen people do number 20, or number 1, but I just like a big suture, so I use a number 2 ortho cord. I use ortho cord because the needle, not because of the suture, but because the needle curvature on the ortho cord suture is much narrower arc of curvature than the fiber wire, so it's much easier to get in that deep little hole to put the stitch in. So I prefer ortho cord. I have a rep asking me to ask you to compare this to the suspensionplasty. Yeah, I'm getting that a lot because I just published the article on suspensionplasty. Let me tell you, I love the suspensionplasty. I think it's a great little device. But you know, if I've been doing this a while, 30 years, and if I stopped innovating every time I got a procedure that I thought was pretty good, you know, nothing would ever get better. And the one thing I see from suspensionplasties, just like any other soft tissue procedure, is that their pinch strength is weak for a while. And sometimes it gets back pretty close to normal, and most patients don't complain because they don't have any pain anymore. But if you actually test it, they're weak. And so I'm trying to just think of a way to solve that problem. You know, and I think any surgeon who's curious would probably want to try a few of these and compare them to his other patients and see how they do. I mean, in the end, it's either going to work really well, do what I say it does, or it's not. And so that's how you advance medicine. If I just sat on the same way, we'd be doing carpal tunnel releases through a 5-inch incision like we did in 1965. Can't do that.